3 million Americans sustain whiplash injuries each year. 1.5 million Americans suffer from chronic pain associated from whiplash, and many more will experience a concussion. Stay tuned because today you will discover the force thresholds for brain and cervical injury and simple strategies to improve vestibulo-ocular and vestibulo-colic reflexes. Hi there, I'm Dr. Krista Burns, founder of the American Posture Institute, and your host on the Virtual Neurology Summit. The purpose of the Virtual Neurology Summit is to provide healthcare professionals with brain-based solutions to help your patients recover from head and neck injuries and improve neurologic function. I'm honored to welcome our next guest expert. Dr. Jason Smith is a husband, father, a chiropractic physician, and a speaker on brain recovery. In active practice since 1998, he is fellowship trained in clinical neuroscience and brain rehabilitation. He believes that brain healing comes largely from simple daily habits. He leads by example and motivates others to take responsibility for their brain health. He's passionate about serving as a guide to patients and forward-thinking practitioners. Today, he'll be sharing with us critical mistakes most doctors make when treating TBI and cranio-cervical trauma. Dr. Smith, thank you so much for joining us today on the Virtual Neurology Summit. Please take it away.
Thank you, Krista, for having me on today. The interesting thing about brain injury is there's usually some kind of trigger. When someone has an impact or an initial injury to their head or their body, they'll eventually have a symptom or a behavior that changes, and that's when it will, they usually present to our office. So they'll either usually have some cervical spine symptoms and signs or mild traumatic brain injury signs and symptoms. And I just want to share with you a recent case study. There was a 33-year-old female that came in to see me, and she had a motor vehicle collision where she was rear-ended about a year ago. And her main complaint was neck and right-sided buzzing sensation all up and down her neck. And she also had some symptoms of intermittent dizziness, some chronic neck and back pain, and also insomnia. This buzzing made it so she couldn't sleep very well. So I did a little research because she brought some x-rays with her, and she said, "Have you ever seen this condition?" And so I'm just going to show you an image of this x-ray, and you just look at it for a second and you'll notice at the bottom, maybe there's some decreased cervical curve, maybe a slight decrease in the joint space. And then as your eyes scan upward, you start to notice up in this area right here, something's a little off. And then let's just jump over to the MRI. Or actually, this is the flexion extension. So she had a flexion extension view, and you'll see that there actually isn't any signs of increased atlantodental interval, but you still notice this gaping gap back here. And if you've thought about what that is, we'll show you the MRI, and then you can see C2 here and C1, and then what is supposed to be right here. And that is actually a case of agenesis of posterior arch of the atlas. And I found a couple different papers, one from 93, another one from 2014, and that's what this patient had. And so I just, she seemed to have some brain injury symptoms when she presented, but we'll talk about some of those mistakes as we go through. Here's another case from that second report. You see the agenesis of the posterior arch, and then you also see the severe spinal stenosis at C3. This patient ended up having, this is just from the case report, he ended up having a C3-4 fusion and completely resolved all his symptoms within 6 months. And they ended up deciding not to do anything about that upper cervical agenesis because his symptoms resolved. So he does wear a neck brace now, otherwise he gets too dizzy. But I just thought that was interesting. I put together this little image, this diagram, to help explain to my patients the critical relationship between the neural component and the active and the passive components in our spine. And the neural component is obviously the brain and the spinal cord and peripheral nerves, whereas the active component is the muscles and tendons, and the passive is the ligaments, bones, and the joints. The neural component has a motor signal, this red arrow that goes down and tells the muscles what to do, and then the muscles in turn move the passive structures. And you see the different colors. Mobility needs to happen for us to move, but stability also needs to be there as well. And this black arrow on the left and this black arrow on the right are really important because that tells us that the passive structures still give feedback to the brain as well as the muscles give feedback when they do the movement. So I just love to share that with patients because it just helps them understand what I do as a chiropractor, but also as a clinical neuroscientist when I'm dealing with brain function. So I'd like to share with you a few of the common mistakes that I've seen. And to be honest, I've made some of these mistakes myself at times. Every case is different and every scenario isn't always ideal, but my goal for you is to just increase your awareness of some of these things that are common that I see doctors and that I've made in myself in the past. So the first mistake is not understanding the force thresholds for brain injury and cervical injury. And force thresholds is an interesting topic because we know how brain injury occurs. We know that there's shearing that occurs at the junction between the gray matter and the white matter, and sometimes it's twisting, sometimes it's broken, but there's specific biomechanics that create this brain injury. And it can be a linear impact to the head where you actually hit the head on something like the ground or the inside of a car. You can also have rotation with impact, but then there's three other types where you can have an inertial impact with or inertial injury to the neck without head impact, and also you can have a sideways or a rotation without impact as well. So how much force does it take? Well, with the recent interest in fighter pilot G-forces, you start to hear that, okay, there's about 5 to 9 Gs is about the maximum exposure limit for humans based on fighter pilots that are exposed to high G forces. And remember, this is a force over sustained period of time, 43 seconds. And the result is unconsciousness from lack of blood flow to the brain, which they term G lock, G loss of consciousness. And you see up in that shaded area at the top of this little graph, that's where G lock occurs, somewhere between 5 and 9 Gs. Blackout is just under there, maybe 5 to 6. Gray out is about 5, and then the cardiovascular reflex sort of kicks in just above 3 Gs. And you notice once again that the time is traveling across, and it's not at the instant you have that G force, but when that sustained force is acting on your brain and decreasing the blood flow. It's obvious that when the brain receives a trauma, the neck is close by. So any significant impact to the head also loads the neck. So that can cause injuries to the neck. All right, well, how much force does it take to injure the brain? Well, the range of linear impact accelerations that can cause a concussion is between 60 and 160 Gs. I mean, that's a lot more force than I would have thought. I don't know about you. The highest predictive occurrence is about 96.1 Gs. So how much force does it take to injure the neck? Just guess. Like, don't just listen. Actually guess for a second. What do you think it is? If you already know, then you know the answer. It's pretty small. It only takes about 4.5 Gs of neck acceleration to cause injuries to the cervical spine. So what does that tell us? Pretty much every brain injury we have, like 99.9% of the time, has some level of neck injury. And that is something that I think is pretty profound. And that's one of the common mistakes that most doctors don't realize, that if you have a brain injury, you for sure have a neck injury. What accelerations cause it? Well, we talked about linear accelerations a moment ago, but the angular accelerations also cause brain damage, particularly in the deep areas of the brainstem, and it's more damaging than the linear. But we don't get to do a scientific experiment on any case because they already are injured. And pretty much we have linear and acceleration forces going through any head impact. So here's the second mistake. Doctors that I see don't know how to closely understand how the symptom profile overlaps for traumatic brain injury and for cervical spine injury. So let me talk to you about that for a moment. What are the common symptoms with neck injury? It's pretty simple: neck pain, headache, some dizziness, and then cognitive deficits. That's pretty common. And then what are the symptoms with concussion? Headache, dizziness, and cognitive symptoms. It's almost exactly the same as the neck injury profile. So there's numerous papers out there that tell us that symptoms don't reliably discriminate between these two conditions. So here's just a chart from that paper. You can see that of these 12 or 15 symptoms, only one of them is unique to cervical spine injury that's not in concussion, and 3 of them aren't in the cervical spine column that are. The CTE, the depression, and memory deficits aren't that common with cervical injury. Another different paper, Brain or Strain, from 2015, it shows that only 2 of these list of 22 symptoms have a significant difference. Headache is a little different, and then the sleeping more than usual. But all the other symptoms do not. We can't, basically the point is we cannot tell the difference between brain injury and cervical spine injury just by symptoms alone. So there's other things to do. So I can't ever let a talk go by without mentioning that only 10%, maybe less, of traumatic brain injury, mild traumatic brain injury cases have loss of consciousness. So that is not a good thing to base on whether or not there is a brain injury. So the third mistake is forgetting to ask patients about certain symptoms. So let's talk about the symptoms. I always like to explain to my patients, and I write it on a whiteboard when I'm talking to the patient after they give me their history, and I write this SPEC on the board. And I say, do you know what that stands for? They're like, I don't know. I'm like, all right, this talks about all the different categories that the symptoms can go into, because I want people to understand, especially when there's a mom with a child, especially when there's a husband with a wife, and you just don't always get this big thing called concussion in the symptom profile. So sleep is the first letter. Physical, things like headache and light and sound sensitivity and dizziness. Emotional, impulsivity, anxiety, depression, so forth. And then cognitive symptoms such as brain fog and memory issues. So those are the 4 simple categories. Just remember this and make sure that when you're consulting with your whiplash cases and with your brain injury cases, that you look at these 4 categories. Don't forget any of them. Now, when I teach doctors, I like to talk about the different phenotypes, which is a little bit more complex acronym, and that's the Coach CV. And that tells us to look for cognitive issues, ocular motor dysfunction, affective, cervical spine headaches, cardiovascular and autonomic problems, and vestibular anomalies. So I literally put that up and just say, check, you have this, check, 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 in case they ever are just, I'm not so sure if I have a brain injury. Well, from these symptom profiles that help us convince our patients that it does definitely have the injury. And we have to remember this one important thing. Ocular motor dysfunction, cervical spine disorders, cardiovascular issues, and vestibular problems can all cause dizziness. So just because you have one symptom doesn't mean that multiple different regions are not affected. So the 4th mistake, which may be the most critical of all of them, is underdiagnosing cervical spine injury. And it's so simple because people over and over are not obtaining sufficient cervical spine injuries to rule out these critical neck injuries. Mark Twain once said, what gets us into trouble is not what we don't know, it's what we know for sure that just ain't so. And to me, what that means is, being a chiropractor and having lots of experience with the cervical spine, and over the last 15 years, getting much more experience with the brain, you think you know something, and that's when you can get overconfident. And this is particularly important for the chronic brain injury cases, because they've been to amazing specialists, brain injury clinics, vision therapists, physical therapists that are expert in brain rehabilitation, occupational therapists, literally a whole bunch of brilliant people. And then I just go through my checklist and I look at that and I'm like, oh, did anyone rule out cervical spine injury in your case? Did they take neck x-rays? Oh, well, no, this is a brain injury. So there was no need to do that. And I had a negative MRI. So I think it's important to differentiate, because then you can ensure appropriate diagnosis and treatment. As much as you treat the brain, you can sometimes overlook treating instability in the spine. So why not start, if you have a chance, by ruling out cervical spine instability? Don't wait until it becomes a long chronic case. And why? Well, 3 reasons. We want to decrease the risk for progressive instability and deterioration of the neurologic system. And we want to make appropriate treatment and active exercise recommendations. So there was a study in 1993 that looked at 740 cervical spine injuries, and 29% of the patients with missed injuries developed permanent neurologic consequences. And guess what the most common error was? Not obtaining an adequate series of the cervical spine x-rays. And in these cases, they could have overcome that permanent complication by just having a standard 3-view x-ray. They're not even talking about the x-rays that I'm going to talk about in a minute, which are really important. And why is this important? Because afferents in the cervical spine integrate and converge with neurons from the trigeminal complex and go down into the upper cervical spine. And one of the most common headaches for neck injury and brain injury is headache. So why not rule out these upper cervical issues while you're doing a good thorough work of a brain injury case? And then think about where the trigeminal nucleus comes from in the brainstem. It's from the pons. And then that means you also need to think about blink reflexes and tear reflexes. So if someone is not blinking appropriately side to side or having appropriate tearing, like a lot of patients that I've seen have chronic dry eyes. So you want to look at those reflexes and learn things that you can do to rehabilitate those brainstem regions as you're treating these patients. And you'll be surprised in just a few days how quick these cases resolve. Maybe it's a few weeks. So let me talk to you about some simple strategies that I've found to help. This is a test, but it's also can be a rehabilitation. So I don't know if you've seen those cases where people just have a really hard time turning their head, or they're just so used to pain when they turn their head that they don't want to turn their head. What I found is to do this head neck differentiation test is magic for some of these patients. Basically, hold their head and they look at a target, and then they're on a spinning stool and they turn their body to the side while they're looking at that target. And so many times, literally 9 out of 10 times, the patient's range is totally improved and their pain is dramatically down. So use that and try that test. Don't just take my word for it, but try it and you'll be so surprised. These head neck differentiation tests are good for vestibular versus cervicogenic dizziness, but also for that vestibulo-ocular, vestibulo-colic reflex feedback loop that's going on. Now, there's another test. Most people who assess brain injury will look at the pursuit system, and they'll just have the patient look at a target in front of them, and that's great. But there's so many studies that say that the smooth pursuit neck torsion test can actually bring some of these dysfunctions to the surface because you turn the head 45 degrees. Now you try their pursuits in the vertical and horizontal direction, and you'll sometimes uncover issues that you didn't know were there. And people will have dizziness as a result. They'll get symptoms while driving, and they'll just have a lot of just weird, mysterious symptoms that you can't quite untangle until you do some of these little tests that I'm explaining. But that's probably one of my biggest tricks is I like to get people to have a decreased symptom as soon as possible while they're in the office so that they know. I mean, the way I look at it is when we're seeing a patient, they're interviewing us, they're like hoping that we can help them, but we also want to know if we're going to waste our time with them and can we help them or not. So one of the best ways you can help someone know that you can help them is to help them. Let them know that you can help them, and you need to find some of these things that will help them make an improved function like right that day. Doesn't mean we're aggressively manipulating things or putting anything in danger. It's just let the patient know that their brain has a neuroplastic ability to heal right up front. But if there's instability in their spine, that is going to decrease their ability to heal. So I just dropped in a picture in this slide to show you that transverse ligament, how important that is. Here's an MRI from the side showing an increased atlantodental interval, which is really important to look for, especially in adults. You'll see it a lot more often in kids, the young teenagers who get brain injuries, and you rule out this. If you can get that neck to heal, those kids respond so much faster. Here's a DMX study I took on a patient. You see in neutral, their atlas is just perched right on their C2. And then we tip them over to the side and you see that atlas shifts and overhangs over the C2. It was a total of 5. I've seen as much as 7 millimeters on one side. So it's pretty important. Now you can do this study with an AP open mouth in your office. Just the trick that I use is I have them open their mouth, protrude their head a little, extend just a slight amount so that their teeth aren't blocking that joint. And then you do the open mouth just like that, tilt it to the side, make sure they don't rotate, their nose is straight ahead, and then do it the other side. And you'll be able to try it a few times, and you'll be able to take those AP open mouth lateral bending views right there in your office. Another view of the upper cervical ligaments, transverse ligament here. The alar ligaments aren't shown. Those are sort of like guy wires that come off the either side of the dens to attach to the cranial, the interior surface of the. Another picture of cranio-cervical ligaments that could be injured. That is anterior and posterior longitudinal ligaments, and then the interspinous ligamentum flava and the nuchal ligament. These are all important to be evaluating because the muscles can develop trigger points that literally can reproduce almost every headache that's possible just from the neck. I know most of you who are chiropractors know that, but don't forget it when you're treating these brain injury cases. So how do you differentiate whether it's cervical instability or cervicogenic dizziness? Well, you have to do some testing, but I really recommend more than the 3-view x-ray for these brain injury, cranio-cervical injury cases. Do flexion extension x-rays, do your open mouth views and lateral bending left and right, and then correlate it. See if you can reproduce some of those symptoms with some of those positions, and you'll find that there's a high likelihood. And then be careful with your autoimmune patients, your rheumatoid arthritis patients, because I took one yesterday and she had almost a 7 millimeter atlantodental interval space. This is someone I've been adjusting once or twice a month for the last 22 years. And we've never adjusted her upper cervical spine because we knew she had rheumatoid arthritis. But that's something to really pay attention to. Now, if you do have some of these following indications, then you want to pay attention to this and don't just let it go by. And that's lesser occipital neuralgia or greater, facial and ear pain, sensation of a bobble head, these upper lower motor neuron signs, and then paresthesias with or without neck flexion. They don't have to actually have flexion at their meet sign to be upper motor neuron lesion. And then just to remind people what the instability radiographic signs are, you need to consider it if the ADI is over 3 millimeters. Some people say 3.5, but it's pretty close. If there's a segmental kyphosis in the spine over 11 degrees, or anterior listhesis of greater than 3.5 millimeters of any vertebra on another, and if that AP open mouth C1 overlaps on C2 more than a millimeter, then you have to at least consider instability of the cervical spine. And then what do? Well, you should measure things, and if necessary and you can't get the good views with your plain film x-ray, then refer out to a digital motion x-ray. And then there's great companies that do third-party mensurations, and then do the MRI with the 3 Tesla magnet, and then have them do the slice so they can actually see the upper alar ligaments. I had a patient referred to me yesterday that was evaluated by another chiropractor, and he did an amazing job. He just wasn't able to resolve some of the other brain symptoms. And then some of these cases do need to have surgical consults, but most of the time, if you treat and decrease their symptoms, they may not be able to go back to playing tackle football, but they can go back to almost all their life activities. So just reviewing, what are some of the common mistakes that doctors make? The first one is not understanding the force thresholds. The second one is not understanding that the symptom profile for brain injury and cervical spine overlaps quite a bit. And then the third thing is just cervical spine underdiagnosis. Don't be one of those doctors that fails to obtain sufficient cervical spine images on these cases where the upper neck could be injured from a brain injury. So that's all I have for you.
Dr. Smith, thank you so much for this excellent overview. Some very, very key reminders that perhaps some of us have forgotten over time. And of course, some great clinical initiatives to implement with your patients. I'm going to do a summary and then a couple of questions. So you talked about triggers to evaluation. So impact and force to the head leads to change in function, symptoms, or behaviors, which is really what drives the patient into your practice. And you shared with us a really interesting example of agenesis, the posterior arch of the atlas of C1. And then you shared with us a really great visual that you give to your patients where it's neural, active, and passive, and showing that connection with neural to active being sensory and motor, passive also having sensory input into the brain. And you talked about stability and mobility, need mobility and stability in order to move. And so demonstrating this to the patient so they understand the process of rehabilitation. And common mistakes that most doctors make. So, number one, not understanding the force thresholds for brain and neck injury. This was very fascinating. Thank you for sharing this. I've never seen it broken down quite like this before. And I think it's really going to stick not only for me, but for our practitioners tuning in. So, shearing at the junction of gray and white matter. Some of the biomechanics include linear whiplash injuries, sideways without impact, and rotational. And 5 to 9 Gs is the maximum exposure limit for humans at a sustained force. You talked about the G tolerance curve. And then when the brain receives impact, it also loads the cervical spine. And you shared with us it's about 60 to 160 Gs cause brain injury, with the average most common being about 96.1 Gs. So very, very interesting there. And then the difference between the brain injury, such as a concussion, and a neck injury being just 4.5 Gs of force. So really, really interesting with the difference there. And then, of course, correlating that every brain injury is also going to be a neck injury. So making sure that we're not missing that. Angular acceleration and linear acceleration. Angular is going to be more damaging, looking at the brainstem area. And then mistake number 2, don't understand the symptom profile overlap. So recognizing that there's very similar symptoms among a neck injury and a brain injury, decreased cervical range of motion being more cervical based and sleeping more than usual is going to be more brain based, but we can't use symptoms alone. So integrating, certainly objective findings when making diagnoses. And then less than 10% of mild traumatic brain injury has loss of consciousness. So we can't use that alone either as a diagnosis differentiator. And then mistake number 3, forgetting to ask about certain symptoms. So you shared with us SPEC, SPEC, which is sleep, physical, emotional, and cognitive for your patients. And then the 7 clinical phenotypes for practitioners, which is COACH CV. So cognitive, oculomotor, affective disturbances, cervical spine disorders, headaches, cardiovascular deficits, and vestibular deficits. And I'm so glad that you put that together there for us in such a practical way. It's a good checklist to make sure that all of these are being evaluated with the 7 clinical phenotypes. And when explaining it to your patients, I love how you gave an example, especially if a mom is there with their kids or a spouse is there. So then they're making connections that it's not just the pain at the injury, but also it's impacting emotional ongoing, cognitive ongoing, because they may not be making that correlation post-injury. So really explaining that to the patient with great communication. And then mistake number 4, underdiagnosing cervical spine injury. And really it's about a failure to obtain images. So need to differentiate to ensure appropriate diagnosis and treatment. Rule out cervical spine instability, absolutely. Decrease risk of progressive instability and neurologic deficits. That was an interesting study. And, it hits home when we see it, that 29% of patients with missed injuries, cervical spine injury, without x-ray develop permanent neurologic symptoms. So that's a good motivation to be inspired to always make sure that we're not skipping over that important step. And the cervical afferents integrate with neurons in the trigeminal complex. So we need to rule out upper cervical issues and then also check blink and tear reflexes, and then looking into rehabbing the brainstem region. You're seeing a lot of dry eyes as an example. And then with our strategy, so we have the head and neck differentiation test. And I want to make sure I have this correct. I think this is very practical. So they're going to hold the head, they're going to look at a target on a spinning stool. What I understood is they hold the head still while moving and rotating the stool. Is that correct?
That's correct.
Excellent. And would they go in both directions, or would it be specific to a single direction?
Well, I always do both directions. Usually they're diminished more in one direction, like they hurt more on right rotation. So I have them do both and show them that one side is better than the other. And then we turn the body the opposite direction, and all of a sudden they can turn their head. And it's really fun for them.
Yeah. And anytime a patient can see a difference pre and post, it's, as you mentioned, you're showing them that their brain is working, you're showing them neuroplasticity. And it's always fun when they can see it, and also a spouse or somebody that's there with them to support them as well can see it. And then smooth pursuit neck torsion test. So test smooth pursuit system for midline cerebellum vestibular nuclei, and test horizontal pursuits in neutral and with the head at 45 degrees. And I was wondering if you could just show that one to us quickly as well. So we want to test smooth pursuits from a neutral position, and then, as you said, move the head to a 45-degree angle. And then, as a practitioner, are you moving to the side and then testing smooth pursuits from there?
Just from that side.
Okay.
So I just test it first, and sometimes people will actually have good pursuits, and it
Yeah.
always confuses me, especially when they have visual symptoms or dizziness symptoms. You're like, well, that's weird. They should be showing something here. But then when I torsion their neck 45 degrees and then I do their test and I still check it, out of convergence, at least 3 feet away, in the horizontal plane and then in the vertical plane, then a lot of times you'll see that integration of the neck is affecting their ability for their eyes to travel smoothly.
Mhm. And then if you see that as if they have a disruption while doing it to the side, is that then that becomes the rehabilitation? So then exercises they would do is then smooth pursuit at the 45-degree angle.
That's the first step. But what I like to do right then is I usually take my arthrostim, a little slight, and if they can't even handle arthrostim, I take a little vibrating toothbrush and put it on their upper cervical spine.
Okay.
And then I'll have them do little 1 inch head movements and then look at the target. And then the other head rotation and look at the other target. So they're literally looking maybe only 1 inch apart at 3 feet away. And then we'll
Interesting.
do slight vibrations with slight head motion. Yeah, we call it head. I got this from Dr. Hatch in Orem. We call it slingshots. So
Uh-huh.
we're turning the head and then the eyes move, and turn the head and the eyes move. And
Okay.
I do that I did my own little variation of his exercise with the vibration and the adjustment.
Uh-huh.
And that literally resets that vestibular ocular reflex, sort of hacks it, because normally when people look to the right, they'll always want to look with their eyes first
Sure.
and then their head will follow. So I'm switching it and making it go backwards. And I don't know exactly why it works, but it really works.
Mhm. Yeah, and also
So
the awareness too. They're focused on, differentiating the movements there. Very,
mhm,
very, very cool. And then would you have the patient doing that at home as well in between visits? Maybe without the
definitely.
vibration that you're doing in
Yep,
office, but
yep.
doing that.
We have them do that at home. Sometimes it's too stressful for them to do it seated. So we'll literally have them lay on their back
Uh-huh.
and get unloaded, and it works great. And then once they can do that, really only 5 to 10 times, but 3 to 4 times a day.
Yep.
And then within a few days, they'll come back and they can do that. And they're so proud of themselves. Look, I can move my eyes 1 inch. And
Uh-huh.
I always cheer them on when they make that progress.
Yeah, definitely. And you can objectively measure it, which is pretty cool too. And then they can feel a
Yes.
difference, which is also
Yeah,
amazing. That's where it gets really life-changing.
exactly.
Wonderful. Well, thank you so much for sharing that. And then also a word on cervical instability. So doing flexion extension x-rays, AP open mouth, also with lateral bending on the left and the right, and then correlate with subjective and objective exam findings. Such a great presentation. Thank you so much for sharing this with us. So important, really great reminders. And again, we just want to empower everybody to make sure that we're being safe, not making these common mistakes. And of course, always putting the patient first when it comes to their rehabilitation programs to help them overcome that strong force that they may have experienced, leading to a head and neck injury. And as we wrap up another great session today on the Virtual Neurology Summit, I'd like to acknowledge Dr. Jason Smith for his excellent work in clinical neuroscience. And to all of our viewers, I'd like to acknowledge you. Thank you for your commitment to brain-based correction and objective clinical results. I'm Dr. Krista, your host on the Virtual Neurology Summit. Be sure to check out the Postural Neurology program to get certified in brain-based postural correction. Stay tuned, and we'll see you on the next Neuro Masterclass of the Virtual Neurology Summit.